Good morning, everyone. Today, our first topic of discussion is pyogenic meningitis. So, in pyogenic meningitis, first we have to know what is the definition of meningitis. Meningitis is inflammation of the leptomeninges. Lepto means the arachnoid and the pyomata, along with inflammation of the leptomeninges, along with variable involvement of the encephalon, that is the brain matter. So what is meningitis? We've known. So meningitis can be acute meningitis or chronic meningitis, and meningitis can also be, according to etiology, bacterial, viral, fungal, and parasitic. Our discussion will of all the case scenarios or of all the questions which we will be discussing will be according to etiology, pathology or pathophysiology, clinical features, investigations, and management. We will be reading under these following headings. So first is etiology. Etiology, we have to know what are the organisms which are responsible for the causation of meningitis, and also what are the predisposing factors. Okay, so organisms, what are the most common organisms and what are the little less common or rare organisms which should be causing. Most common organisms are, actually this will be according to the age, but for UG level we can go with the few common organisms. So the most common organisms, this you have to remember, you have no other option. So Neisseria meningitidis, Streptococcus pneumoniae, and Haemophilus influenza. The less commoner organisms are Staphylococcus, E. coli, and Pseudomonas. Now, what are the predisposing factors? These are the organisms. Predisposing factors are, one, the child is in sepsis, that is septicemia, or if there is a septic focus in the skin or lung or bone. Sickle cell anemia. This is a Viva question also. Sickle cell anemia, the most common organism will be pneumococcal meningitis. Okay. Next important is immunocompromised states like HIV, A-gamma globulinemia, hypogamma globulinemia, and complement deficiency. The other conditions which are predisposing to this pyogenic meningitis is malnutrition and ventriculoperitoneal shunts, VP shunts, or any other cochlear devices. All these are conditions which are predisposing to our pyogenic meningitis. Okay. So next, what is the pathogenesis? There are two ways of spread. That is either hematogenous spread or contagious or contiguous. It's not contagious, it is contiguous, sorry. Contiguous, that is from the nearby regions. So anywhere if there is direct hematogenous spread will be via blood, and then the contiguous spread is nasopharyngeal colonization will be there with the organism. Then it will go into the bloodstream. Organism or directly hematogen is spread to the bloodstream. The organisms will be lodging in the choroid plexus. There will be CNS infection. CNS involvement. CSF will be contaminated. Okay. Now coming to clinical features. The clinical features are fever, headache, photophobia, vomiting, bulging AF in small children if it is not closed already. Okay, seizures, meningism, and the sixth, cranial nerve palsy. This is a viva question again. In meningitis, the most common palsy is sixth nerve, cranial nerve palsy. So cranial nerve palsy we'll discuss in another video. So rarely we can find focal neurological deficits and papilledema. The signs which can elicit is neck rigidity. This is classic. Kernick's sign and Rudzinski's sign. Okay. Now, if brain parenchyma is involved, that is features of parenchymal involvement. That is, if brain parenchyma is involved, then other than the meninges, that is the overlying covering, there will be altered sensorium such as stupor, coma or obtundation, seizures which may be partial or generalized, and focal neurological deficits, FNDs. All these are clinical features. Some extra CNS features, like meningitis means CNS, but other than CNS we can find some features, extra CNS features which are important to remember are rash, petechiae, arthralgia, and shock. Okay, so these are the clinical features. We have discussed etiology, pathogenesis, clinical features. These are just the important points only for examination point of view. For core concepts we will discuss in detail later. So next, what are the investigations which we will do for pyogenic meningitis? First is LP, lumbar puncture. When do you do? As soon as we suspect meningitis. LP is again repeated after 48 hours for two reasons. One, if there is no improvement, or to monitor the improvement. While doing lumbar puncture, we will look at opening pressure, that is with how much of gush it is coming out. Opening pressure high in acute meningitis. Then we will be sending CSF for total count and differential counts. We'll be sending for CSF for glucose and proteins, CSF culture and sensitivity. So now we are reading only about pyogenic meningitis. So we'll see only about pyogenic meningitis. In pyogenic meningitis, gross appearance is turbid. Sugars or glucose will be less than 40 milligrams per deciliter. The CSF blood sugar level by blood sugar level, CSF sugar level to blood sugar level ratio will be low. The protein is around 100 to 500 milligram percentage. Cell count is elevated, that is up to 1000. Differential count will be predominantly neutrophils. Okay, so these are the main investigation for meningitis. Other investigations which you can write is complete blood picture, blood culture sensitivity, CRP and CT. Sometimes it is not routinely used. So this is about investigations. Next is, or the final thing is, management. Management, the first step is we have to start with antibiotic. Antibiotics should be in such a way that it should be bactericidal and should penetrate the blood-brain barrier. Now at present we are starting a monotherapy with a third generation cephalosporin, that is either cefotaxime or ceftriaxone. The dose of cefotaxime is 200 mg per kg per day. Ceftriaxone is 100 mg per kg per day. Assess for 48 hours. You assess for 48 hours, and if there is no response, then we add vancomycin or treat according to culture report. Next, duration of therapy, antibiotic therapy is 10 to 14 days. After antibiotic, the next drug is dexamethasone. Should be given 15 minutes before the first dose of antibiotic. Dose is 0.15 mg per kg per dose, 6th hourly for 3 days. No need of prophylactic anti-seizure medication. Then we have to put the baby on IV fluids, daily maintenance therapy, and the baby should be nil per oral for first 24 hours. For raised intracranial tension, 20% mannitol is given. So this is about